Welcome to The Explainer. If you've ever had that nagging and comfortable feeling in your upper stomach, you know just how frustrating and confusing it can be. Well, today we're diving into the official clinical guidelines for symptoms like indigestion and heartburn to help you understand what might really be going on.
Okay, so here's our game plan. First, we're going to define what these symptoms actually are. Then, we'll dig into how doctors figure out the cause and what the treatments look like. We'll also put a special focus on GERD and then wrap up with some really crucial advice on the long-term use of medication.
All right, first things first. What are we even talking about when we say dyspepsia? You might have heard the term, but let's break down what it actually means.
So, the official medical term is dyspepsia. And really, you can think of it as a kind of catch-all phrase for that uncomfortable feeling right in your upper stomach. The main event is usually pain or discomfort, but it can also bring friends, like bloating, nausea, or that annoying feeling of getting full way too fast.
And listen, if this sounds familiar, you are definitely not alone. It is incredibly common. We're talking about a huge chunk of the population here. Studies show it affects up to 40% of people. This, of course, leads to the million-dollar question for anyone who's going through this. What is actually causing all this discomfort? Now, this is where it gets really interesting. This data comes from gastroscopies. That's when a tiny camera is used to look inside your stomach. And what's pretty surprising is that in the vast majority of cases, we're talking 59%, everything looks completely normal. This is actually super reassuring for a lot of people because it means you can rule out the more serious stuff. The other common causes are things like reflux disease or ulcers. And while we're on the subject of ulcers, let's just go ahead and bust a common myth. The research is actually very clear. Everyday stress or drinking alcohol does not cause ulcers. The only kind of stress that's linked to them is extreme physical stress, like what a person might experience in an intensive care unit. Now, smoking, that's a different story. It is a factor, and it can make certain types of ulcers more likely to come back after you've treated them.
Okay, so we know what dyspepsia is. The next logical step is, how do doctors actually figure out what's causing it for you and find the right path forward? So, the first big decision a doctor has to make is whether a patient needs to get a closer look with an endoscopy, that camera test we mentioned. And it turns out it's not necessary for everyone. The guidelines are actually very specific about this. An endoscopy is strongly recommended if you have any alarm symptoms, and don't worry, we'll define those in just a second, or if you're over the age of 45 and dealing with new symptoms. It's also recommended for folks who have to take anti-inflammatory drugs like ibuprofen for a long time. And here they are. These are the specific alarm symptoms that doctors are trained to look for. We're talking things like having trouble swallowing, persistent vomiting, any signs of bleeding, losing a lot of weight without trying, or finding a new lump. If you're experiencing any of these, it signals that a more urgent and thorough investigation is needed. Now, for younger patients who don't have any of those red flags, the approach is totally different. It's a pretty simple strategy called test and treat. First, you get tested for a common stomach bacteria called Helicobacter pylori, which is known to cause irritation and ulcers. If that test comes back positive, you get treated with antibiotics. If it's negative, the diagnosis is usually something called functional dyspepsia, which basically means there's no visible cause for the discomfort. So once the path is chosen, whether it's an endoscopy or that test and treat strategy, what do the treatments actually look like? This is such a crucial point. The guidelines make it very clear that just trying out an acid-reducing medicine, what's called a PPI, isn't a reliable way to diagnose the problem. And you might ask, why not? Well, because if you feel better, it could just be a placebo effect, or your symptoms might have been getting better on their own anyway. A proper diagnosis is really key. And that brings us to the main class of medications used, proton pump inhibitors, or PPIs. You can see the most common ones and their doses here, but the real takeaway is this. They are all considered to be equally effective. So the choice of which one to use often just comes down to what's most affordable. Okay, let's zoom in for a moment on a specific condition that a lot of people have heard of and often confuse with general dyspepsia, GERD. So GERD, that stands for gastroesophageal reflux disease, is diagnosed when the main, most dominant symptoms are that classic burning feeling of heartburn or acid backing up into your throat. It's this very specific symptom profile that really sets it apart from general dyspepsia. And the treatment for GERD is really logical. It follows this step-up approach. You start with lifestyle changes, things like weight management or propping up the head of your bed. If the symptoms are mild, an over-the-counter antacid might be all you need. It's for the more frequent or severe symptoms that a doctor will then prescribe those PPIs.
And that brings us to a really, really critical topic in the guidelines, the follow-up and long-term use of these powerful PPI medications. So, when is it actually appropriate to be on these medications for the long haul? Well, the guidelines are clear. It's for specific, serious conditions. Things like severe reflux disease, or a condition called Barrett's esophagus, where the lining of your food pipe actually changes. It's also for patients who have to take other meds that could cause ulcers. What it's not for is general, uncomplicated functional dyspepsia. Now, have you ever wondered why it can be so hard to stop taking these pills? A major reason is something called the rebound phenomenon. After you stop, your stomach can temporarily go into overdrive and pump out extra acid, which makes it feel like your symptoms are coming right back. But the important thing to know is that this is often temporary, and it doesn't mean you're dependent on the medication. And this is exactly why your doctor might recommend tapering off the medication gradually. By reducing the dose slowly over a few weeks, instead of just stopping cold turkey, you can help minimize that rebound effect and make it a whole lot easier to come off the treatment successfully. Finally, for those who do need to be on PPIs long-term, the guidelines recommend an annual review with your doctor. This is basically a checkup to make sure the medication is still necessary, to check in on your symptoms, and to create a clear plan for the year ahead, always with the goal of being on the lowest effective dose possible. So, we'll leave you with this final thought. Understanding the framework for how all this is managed is actually really powerful. Knowing the right questions to ask can make all the difference. So, how can you use this information to have a better, more effective conversation with your own doctor?